Hello, everyone, and thank you so much for joining our important briefing on CURES 2.0, a critical piece of legislation before Congress right now. And I'm so glad to see all of you here today. I know there's been a lot going on in women's health lately, so thanks so much for giving us your time today. Before we jump in, I want to extend a special welcome to our Corporate Advisory Council members, who are such a vital partner to all of our work here at HealthyWomen, as well as to our moderator, Arika Pierce. Arika has a strong background in health policy, and I'll tell you a little bit more about her in a moment. And of course, I want to give a huge thank you to all of our panelists. For some background, let's level set on CURES 2.0. This is the second iteration of a bill that was originally passed in 2016. It includes several key provisions that need reauthorization by the end of 2022. There are measures that these are measures that would advance medical research, improve access for patients to new medicines and new treatments, provide support and education for caregivers, and remove many of the barriers that still exist for telehealth services. At HealthyWomen, we know that for women to lead long and healthy lives, they need all these things. In particular, they need reliable access to high quality medical care and the ability now to receive that care in their own home via telehealth. They also need clinical trials that better account for women's biological differences when developing therapeutics. And because women still own that core responsibility for most child and elderly care in this country, they need real support for that role. CURES 2.0 would go a long way to ensuring that these essential services are available to all American women. And after more than 2 years of the COVID pandemic, this legislation has never been more urgent. And that's why we believe it is so important for Congress to pass this legislation. At HealthyWomen, we know that this legislative package will give women the resources, the tools, and the treatment advancements to improve their own health and the health of their families. To discuss this legislation further, we have an impressive panel joining us today. Our moderator is Arika Pierce, a leadership development coach and a president and founder of Piercing Strategies. Arika has extensive experience in healthcare from her years of working in the Senate on healthcare policy and in the corporate world for HMS, now Gainwell, a healthcare technology company. Given her background, I know Arika is going to lead us in an engaging conversation today. So with that, Arika, are you ready? Because I'm going to toss the program over to you.
I'm ready. Thank you so much, Beth. And thank you to all of you who have taken time to join us today. And I think we would all agree that there is probably not a better time to have a discussion around this very timely topic, as we know that the House of Representatives is currently working to advance the CURES 2.0 legislative package within their committee. So as Beth shared, this is legislation that was passed back in 2016, led by Representatives Diana DeGette and Fred Upton. And today, CURES 2.0 is building on the programs and financial investments that were made in that first package and that have received bipartisan support in both House and the Senate. Because CURES 2.0 is such a large piece of legislation, we wanted to really spotlight 3 specific provisions today. We are most excited to talk about the provisions related to Title II, Patients and Caregivers, Title III, the FDA, and Title IV, CMS, or Centers for Medicare and Medicaid Services. Before we get started, I want to briefly introduce the experts that we have here today. We have Dr. Fawn Cothran from the National Alliance for Caregiving. We have Jeannine Brant from the Oncology Nursing Society. We have Nisha Quasba from Faegre Drinker, and we have Ashira Ventries from AIMS Alliance. So thank you so much to our esteemed panel. And we'll start with Dr. Fawn Cothran. Just to give you some background, she currently serves as the Hunt Research Director at the National Alliance for Caregiving. She has over 15 years of experience in dementia, family caregiving research, and related activities. She's a nurse scientist, a board certified, let me hopefully pronounce this correctly, and correct me, Dr. Cothran, if I say it incorrectly, gerontological clinical nurse specialist. She has a bachelor's in nursing from Howard University and has also completed a master's of nursing, science in nursing with emphasis in gerontological nursing, and a doctor of philosophy, both from the University of Michigan. She's completed a Claire Fagan postdoctoral fellowship with the National Hartford Centers, and she's also a fellow of the Gerontological Society of America, a member of the National Black Nurses Association, and a distinguished educator in gerontological nursing education. Wow, Dr. Cothran, incredibly impressive. Please take it away.
Thank you, Arika. I appreciate the introduction. It is my pleasure to be here today, and it is my honor to speak to you today from the traditional Nisha territory. The work of the National Alliance of Caregiving supports a society that values, supports, and empowers family caregivers across chronic condition and lifespan to thrive at home, work, and life. I'm using the RAISE report to Congress's definition of family caregiver to put us all on the same page. It is a family member or other individual who has a significant relationship with and who provides a broad range of assistance to an individual with a chronic or other health condition, disability, or functional limitation. Next slide, please. Two headlines from this year set the stage, emphasizing the impact of caregiving overall and the impact on youth caregivers. Next slide, please. I want to focus on three important family caregiving reports: Caregiving in the US 2020, Caregiving in a Diverse America, and Home Alone Revisited. I hope you have an opportunity to skim the executive summaries, and if you are interested in digging deeper into the complexity of family caregiving, I recommend these reports in their entirety. Next slide, please. There are 53 million unpaid family caregivers, the majority of whom are women. Family caregivers provide 23 hours per week of care, the equivalent of a part-time job, and over 60% are also working. 58% of caregivers assist with medical nursing tasks, including injections, medication management, wound care, tube feedings, and other complex care responsibilities. 40% of caregivers live with the person they care for, and 1/4 of caregivers are caring for someone with Alzheimer's disease. While caregivers represent every generation, boomers are providing the bulk of care, but Gen X and millennials are not far behind. Next slide, please. Given some of these statistics, family caregiving across the lifespan can present various challenges, including stress, invisibility, reduced work, physical and mental health outcomes, nutrition and immune function changes, as well as isolation. I do want to clarify that when I speak about the challenge of invisibility, caregivers and all they do are often not seen or recognized as the valuable team members and experts that they are. Next slide, please. Despite the many challenges of family caregiving, I also want to acknowledge the positive benefits, including sense of purpose, satisfaction, opportunity to resolve conflict, strengthening relationships, and a way of giving back. Next slide, please. A few more recent headlines to illustrate how COVID-19 has affected women who are family caregivers. But the reality is that family caregiving has always affected women. COVID-19 only amplified the impact. Next slide, please. 60% of women are family caregivers, and it is a gendered role based on socialization and expectations. Women are more likely to care for more than one individual or care for more than one generation, often repeating the role. Women are more likely to be informal or unpaid caregivers and formal or paid caregivers. Next slide, please. Other challenges for women include the feminization of poverty, or the overrepresentation of women in poverty, reinforced by the persistent gender wage gap, early workforce separation, which influences short and long-term financial security, and worsened health outcomes, with heart disease, cancer, and stroke the three leading causes of death in women. When intersecting racial and ethnic identities are reflected, the challenges intensify. Next slide, please. Provisions from CURES 2.0 has the opportunity to benefit caregivers in three specific areas. First, to establish initiatives that enhance the federal support infrastructure for family caregivers in public health, leave policies, and social support assistance. Second, training and information on caregiver health self-management, as well as how to perform specialized skills such as medical and nursing tasks that ensure caregiver confidence and continuity of care between healthcare visits. Third, contributing to a better field of data collection for clinical research design and measurement in medications, medical devices, and disease impact through pivotal insights from diverse communities of family caregivers. Next slide, please. I share my favorite quote from former First Lady Rosalynn Carter to provide perspective. There are only four kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. Thank you. Next slide, please. Please register for our World CARES Conference next week, convening carers and care advocates from around the world to talk more about innovations in caregiving research, practice, and policy. Thank you again.
Thank you so much, Dr. Cothran. That was incredibly insightful. I did not realize that there were 53 million unpaid caregivers in this country. So that's great information to know. As you shared, the pandemic, in many ways, it spotlighted the fact that women are the primary caregivers, but you said this is not, something new. But that said, what do you think has been the biggest challenge for caregivers as a result of the pandemic?
Yeah, actually, it's not just one thing, to be honest with you, because everything is so interconnected, but because a lot of those services that are typically available for caregivers were lost, as well as support networks due to the pandemic. And so caregivers, as a result, were even more isolated. And as a result of that isolation, that increases stress and the impact on mental health. And again, because caregivers didn't have a break, there were no resources, there was no anything. So that impacted them quite a bit in terms of, like I said, the isolation piece, but it's all connected.
That makes a lot of sense. I know, especially in the very beginning, especially those, mothers primarily who were caregiving for special need children. They did not have access to the typical resources that they had. So that I can definitely see how that could take a toll across all realms of a caregiver. Thank you for highlighting the importance, though, of the needs to make sure that we're caring for our caregivers. So now we'll move to Dr. Jeannine Brant. Dr. Brant is an oncology clinical nurse specialist, and she is the executive director of clinical science and innovation at the City of Hope Cancer Center in California, as well as the incoming president for Oncology and Nursing Society. She's recognized as a community, regional, and national expert on cancer, pain, and symptom management and palliative care. She has served on the Joe Biden Moonshot Panel, Clinical Trials Workshop, the National Quality Forum for Opiate Use and Use Disorder Panel, and the American Nurses Association Palliative Care Steering Panel. Her work in disparities has included being the director of Women Reaching for Wellness program, which promoted cancer education, prevention, and early detection in Native American women. Dr. Brant has more than 150 contributions to the literature and has delivered more than 200 national and international seminars on her areas of expertise. Thank you so much, Dr. Brant, for joining us today.
Thanks so much, Arika. I'm really delighted to be here today. And I would first like to thank HealthyWomen for sponsoring this important event. And I'm thrilled that all of you are joining us today because of your interest in health policy. So first of all, too, I'd like to thank, and you can stay on the first slide if you would, please, but I do want to thank Representatives DeGette and Upton for their continued leadership on the CURES initiative. At our meeting a couple of weeks ago for the Oncology Nursing Society, we actually gave them our President's Award. We wanted to recognize them for their bipartisan support for the U.S. Congress in passing the 21st Century's CURES Act several years ago, and for working with us to achieve this again. We also represent 110,000 U.S. oncology nurses and their patients who have benefited from this critical work from the 21st Century's CURES Act. So of course, that's improving discovery and development of cancer treatments in this country. And so we strongly encourage the passage of the CURES 2.0 Act to continue to modernize the delivery of treatments to patients. So I'll try to be judicious of your time, and I'm going to talk about 3 key areas. The first has to do with the patient's voice in this work. The second, I'm going to just touch on patient and caregiver implications. And the third, I'm going to talk about the role of the oncology nurse in honor of Nurses Week. Next slide, please. So capturing the patient's voice is really foundational to all titles within the CURES Act. Sadly, it's estimated that only about 20% of organizations across the US routinely collect what we call patient-reported outcomes. And this is the patient choosing an electronic tablet or a form to tell us about their depression, fatigue, pain, and other symptoms. Clinicians might ask, are you depressed? But the research shows the patients underreport problems when asked. And clinicians, sometimes we assume and we underestimate. Therefore, we really need platforms and workflows that can support these patient-reported outcomes so that we can have a complete and holistic picture of what's going on with the patient. There's a lot of platforms that exist. ONS created a platform, but we need resources to really fully implement these new systems. We have a gate at City of Hope that says there's no profit in curing the body if in the process we destroy the soul. And I think that is the essence of patient-reported outcomes. It keeps the soul intact and provides holistic data about the patient's individual story. The patient-reported outcomes also support Title III FDA Section 302, which encourages grants for novel trial designs for like clinical trials, innovative drug development. But we can have the best technologies and drugs in the world, but we need to know what is happening with the patient. So it includes patient experience data to further build the science in these areas. Next slide, please. Let's talk about patients and caregivers. Title II contains important provisions to improve clinical trial diversity and increase access to clinical trials among populations that are typically underrepresented in enrollment. I have firsthand experience with our Native American population in Montana. One of our first trials was to try to accrue patients to clinical trials. After 5 years, we accrued only 5 patients, and I can tell you a little bit about why. First of all, benefits of clinical trials range from extension of life to disease stabilization to enhanced symptom management. And ONS supports unencumbered access to participate in these trials in order to deliver comprehensive care. And we do strongly advocate that racial, financial, and cultural access barriers be eliminated. However, one of the most important things needed is to build relationships and trust among disparate communities so that they understand our unconditional intent to serve them. And so trust is often lacking, and nurses really can play a pivotal role in this space. I did have the privilege of serving on the clinical trials working group for the Joe Biden Moonshot Initiative, and I know that there's several attempts to really open up clinical trials for all populations. Second, advances in the understanding and application of cancer genetics and genomics have really changed the practice and implementation of cancer risk assessment, risk reduction, cancer prevention, screening, diagnosis, therapeutics, options for personalized healthcare. These innovations really can shape the future of cancer detection and treatment options. And as a research scientist, we have a study going on right now. We screened over 20,000 patients in primary care settings, and we're testing these individuals at high risk to see if they have genetic mutations. But a lack of infrastructure really exists to do this routinely. Patients also fear insurance discrimination, and these tests do cost. Within our study, they are free of charge, and so we're really getting to know about patients' perceptions of these tests. So Title IV of CURES, which provides measures to expand access to genetic testing and precision medicine, really needs to consider these patient barriers. Let's talk about telehealth too. It's been an especially helpful tool for cancer patients. Telehealth has helped us maintain communication and protect vulnerable patients, and it really helps the safety of both patients and staff during the pandemic, especially so that they didn't have to come into the healthcare facility. Increased access to telehealth, though, has also facilitated continued participation in clinical trials for many patients, which is often crucial to their care. We strongly support making permanent the new flexibilities or waivers that were established in response to the COVID-19 pandemic that expanded the use of telehealth services and provided payment parity for telehealth and in-person visits. Nurse practitioners are providers that use telehealth, and we strongly support reimbursement for their services. Next slide, please. So in honor of Nurses Week, I want to say a couple words about nurses. And I know Dr. Cothran is also a nurse on the call today, but I want to talk about their role in care in general. Nurses really help patients navigate through the cancer journey, and they assist caregivers as well, from prevention to early detection, through treatment, cure, and even through end-of-life care. They're collaborators. They often lead clinical teams, major initiatives in healthcare throughout the U.S., and they provide infrastructure for clinical trial enrollment. So as nurse practitioners, they're providers, and they're holistic. And oncology nurses focus on the relationship with the patient as a whole person, along with the entire family. And because of the unique training of nurses, they're highly skilled in obtaining patient-reported outcomes and patient experience reports. Also, we nurses, we're scientists. And I know Dr. Cothran is also a scientist along with myself. So we are discovering new knowledge, advancing care not only in the US, but around the world. In closing, ONS supports oncology nurses and all nurses from a variety of roles to be at the policy table to discuss these critical healthcare issues. And as a Swedish economist and diplomat once said, constant attention by a good nurse may be just as important as a major operation by a surgeon. So thanks for your time today.
Thank you so much, Dr. Brant. So I would like to ask you, you highlighted the fact of how important it is to make the waivers that occurred during the pandemic for telehealth, to expand that, to make them permanent, as well as ensure that the reimbursement rates are at the same levels. Can you just share with us any anecdotal perhaps stories or what you know about how effective telehealth is for oncology patients?
Yeah, thanks, Arika. So while I'm working at City of Hope, I'm a resident of Montana. We're a very rural state. Some patients travel 5 to 7 hours to get to us. During the pandemic, of course, we provide palliative care to a lot of patients and their families. And we had a patient who saw us in the healthcare setting and then went home 5 to 7 hours away. The weather was bad. They couldn't come for a visit. There were no symptom specialists in the community up there. The patient had intractable pain. And so our nurse practitioner and our palliative care team were able to see that patient on a telehealth visit. Second quick example is that we had a study looking at depression in adolescents, and we were providing some follow-up measures. Prior to the pandemic, we had a hard time getting kids to come in for their appointments and follow up. They have school, they have a busy schedule. Once we started using telehealth, the kids really enjoyed it. It provided some social interaction during the pandemic, and we actually increased our follow-up visits, and that was all done by a nurse practitioner. And with these waivers, nurse practitioners were able to expand their services in telehealth and provide the care that patients and their families needed.
Thank you. We appreciate that. That helps really showcase how important these provisions and expansions of the waivers would be.
Great, thank you.
Our next speaker is Nisha Quasba, who serves as advisor in Faegre Drinker's consulting practice, advising on matters related to public health policy. Prior to her time with Faegre Drinker, Nisha served as a public health specialist with the Association of Public Health Laboratories, liaison between government agencies, the association's membership, and policymakers. In this role, she monitored federal and state legislation and regulation regarding newborn screening, emerging outbreaks, emergency preparedness, and global health. Nisha, welcome to today's discussion.
Thank you, Arika. Can everyone hear me?
Yes.
Great, perfect. So first and foremost, I want to thank, of course, HealthyWomen for sponsoring this event, and the two previous speakers, Dr. Cothran, for discussing the profound impact of caregivers, and who we just also spoke to, and heard from was Dr. Brant, for touching on the clinical importance of telehealth, because what you're going to hear from me today is really shedding some light on the policy nuances we have before us, specifically in the telehealth space. I know you just heard a little bit about myself. I've been at the firm and worked specifically in the federal policy advocacy consulting practice, and really work as a government affairs lobbyist for a number of our clients in the healthcare sector. Specifically really looking at healthcare providers, along with patient advocacy groups that are really focused on telehealth and seeing the advancements of these policies that we've seen during the pandemic. I also do represent the American Telemedicine Association, and along with their advocacy branch. So next slide. So given today's panel is really specifically touching upon telehealth policy as it relates to CURES 2.0, I'll focus on two sections that are outlined here. The TICE Act, which really is specifically in the Medicaid space, and the Telehealth Modernization Act, which touches on Medicare. I'll provide a quick overview of what telepolicy has been prior to the pandemic, during the pandemic, and where we think we're going in the next couple months and really into next year. And what are the sticking points from the policy side and where the hesitations lie. Next slide. So we'll focus on Medicare first. As you already know, it's a federal program that pre-pandemic were really restrictive as a telehealth policy is really based upon the definitions that were outlined in statute. So I know this might be a little confusing to follow, but think about it in kind of three columns. So let's first talk about the patient itself. So a patient had to be in what's considered a geographic site that was defined as a rural health professional shortage area. Second was the originating site. Patients were located and limited to a healthcare facility that could include a critical access hospital, a physician office, a community health center, and a number of those type of facilities. And a facility fee. So CMS required telehealth services to be billed with a specific code to indicate that telehealth services were provided and paid the provider the facility rate. That's a patient kind of restrictive aspect. Second was the telecommunication system. So the modality was limited, meaning that service must be delivered as defined in the regulation as a synchronous audio video visit. meaning an audio-only visit was not reimbursable. Also, CMS kept a very restrictive list actually, of allowable Medicare telehealth services, meaning not all kinds of services were included and covered. In that third bucket on the right-hand side, you'll see a remote practitioner, meaning only certain practitioners were allowed to be reimbursed for telehealth services, and certain distance site providers were not included, meaning federal qualified health centers and rural health clinics were not considered distance site providers and could not be reimbursed for telehealth services that they could easily have provided. So what is on this slide and what I just kind of outlined is pre-March 2020. We can go to the next slide. So what happened in 2020 when the country completely shut down, and something that Dr. Brant really touched upon was the clinical importance of allowing patients to continue to access their physicians and not disrupt their care. So Congress required what's called the CARES Act, had passed the CARES Act in March of 2020, to waive some of these policies, along with CMS had some authority to do so as well. And we'll just walk through each one. I kind of touched upon them. So one, the origination and geographic site were completely waived, meaning the patient did not have to live in what was considered a rural health professional shortage area, and they could actually receive their services in their home. Second was CMS allowed for about 200 codes for temporary coverage through calendar year of 2023. Three, the definition requiring video only, synchronous video only visits was waived, and audio and phone visits were counted and reimbursable. Fourth here is remote patient monitoring. I know this is something that we didn't talk about in the previous slide, but CMS allowed for the payment for remote physiological monitoring of a patient, which includes the time it takes to train a patient to use a device. These sort of devices are ones that you might be more familiar with, as like a Holter monitor or a pacemaker, where there's actual information collection and transmission of patient health data that's going from the patient to a provider, and that device and hardware and software is still kind of in the wonks of regulations right now. But during the pandemic, CMS allowed those services to be delivered to new patients, as well as established patients, meaning those who continue to have chronic and acute conditions were actually able to utilize these services. And lastly, during the pandemic, an extension of the providers that were already allowed to be eligible to provide telehealth services. We also saw physical therapists, OT, so PT, OT, and speech therapy were included as eligible providers. And sorry, I'm just seeing on the slide as well, is that FQHCs and rural health clinics were also considered distance site providers. So I know I rattled off a number of facts and kind of some like statutory changes, but really the takeaway was there were a lot of flexibilities, a lot of that restriction that we saw in the previous slide was relaxed during the pandemic. So let's go to the next slide. So as I just noted, those were temporary policies that were tied to the declaration of a public health emergency. The first time it was declared was in 2020, and every often it gets kicked off. It keeps being extended. So from 2020 up until actually today, we continue to be in a public health emergency. But some of these policies are tied to a public health emergency, meaning once the PHE is called off, a lot of what we just discussed and what we've been able to see in this discussion, telehealth goes away, which is what is considered a telehealth cliff. And so what occurred for really a good portion of last year, in addition to this year, was the next must-pass legislation that was up for the docket from last year into this year was the funding of the government, funding of the U.S. government. And so we saw passage and signage of the funding, which is called FY22, the omnibus, which included a lot of big wins for the telehealth community. What does that mean? Meaning that some of these flexibilities are not going to end at the time of when the public health emergency ends, and actually will continue to be alive for about 151 days post PHE expiration. That's about 5 months. And so which of those policies were included are outlined here. So one, Medicare beneficiaries will continue to get telehealth services from any geographic area whether they're in their home, from the comfort of their home, or anywhere that they want to be. Second, the expansion of practitioners continues on, meaning OT, PT, speech therapy, that those providers will continue to be able to provide telehealth services. The roughly 1,400 FQHCs and the 4,300, quite a number of facilities, are going to be able to continue to provide telehealth services. There was one other item that we didn't touch upon, which is in-person requirement for mental health. So in the beginning of the pandemic, Congress expanded access and allowed telehealth visits to be permanent part of the Medicare program. However, post-PHE, an unnecessary guardrail would go into effect, which providers would be required to see their patient in person no more than 6 months prior to conducting a telehealth visit. The bill actually will delay the implementation of this requirement until about, once again, 5 months after the PHE, so it aligns with some of the other flexibilities. Audio only will be allowed. And in addition, on this slide, you'll see Congress continue the safe harbor for high-deductible health plans to offer telehealth services pre-deductible for the remainder of this year. And so there'll be all to say that in March of this year, a number of the flexibilities that we saw during the pandemic will continue post-pandemic for 5 months. Not to say we got all the wins, but a good number of them were included. Congress also in the omnibus were instructed instructed HHS, CMS, OIG, and MedPAC to analyze the utilization of telehealth in order to inform Congress moving forward how to work on a really permanent fix or some form of legislation in the future. Future being 2023, 2024, really reading the tea leaves are very TBD on that. But I would be amiss to say that we got all the wins. There's still probably a number of issues we still have, one being permanently waiving the requirement that patients must receive an in-person evaluation prior to being prescribed a controlled substance via telehealth. That continues to be an issue, and that will expire at the end of the public health emergency. That does not get extended that 5 months after expiration date. And the second piece that we didn't touch upon yet, but I will in a couple of slides from now, is licensure issues. So during the pandemic, states relaxed their professional licensures to allow providers in one state to see patients in another state where they may not have where the provider may not have had a license. Next slide, please. Something, we didn't talk about Medicaid yet, but want to note that Medicaid is a state-by-state run program. Not many barriers at the federal level actually apply to Medicaid at the state level. There's been some confusion at the state level and by Medicaid state programs that they must follow federal Medicare restrictive telehealth policies, which is not actually the case. What you'll see on the slide right here, CMS has done technical assistance and provided explanation to states that the restrictions that are on the federal level actually do not apply to them. And so Medicaid and commercial insurance, though, usually actually follows Medicare's suit. Actually, when it comes to telehealth, they actually don't. So the federal level is just so restrictive. Let's go to the next slide, and now I'm going to kind of relate everything that we've spoken about to CURES 2.0. Going back to my first slide, that there's 2 sections that really touch on telehealth. One is Telehealth Modernization Act, really to just say, I'm not going to kind of go through the same flexibilities, but basically Section 430 of CURES 2.0 takes the Telehealth Modernization Act, a bipartisan, bicameral bill that essentially clearly amends the Social Security Act and allows CMS to continue their flexibilities beyond the pandemic. Even though we saw so many wins in the omnibus, keep in mind that those are still temporary in nature. They still will expire 150 days, so 5 months after the PHE. And so we can go to the next slide. Next is the TIKES Act. So in Section 402 of CURES 2.0, the language mirrors actually a bill that was introduced in the fall of 2020 by Representative Blunt Rochester and Representative Burgess. So it's a bipartisan bill on the health side, really aimed at increasing telehealth access, particularly for children. it's actually TICE stands for Telehealth Improvement for Kids Essential Services, or TICE Act of 2020. Has a number of provisions that really require teledelivery of service to be covered, recommend voluntary billing codes, simplification of actually provider licensure. And so this is another bill that has been kind of in the congressional atmosphere that was also included in CURES 2.0, but really from the Medicaid space. I would say predominantly most of my presentation is on the Medicare space, but I would go amiss by not mentioning this section as well. We can do the next slide. So though there's been substantial wins and headway made in the past couple of months, and the telehealth community largely has been satisfied with the wins, there's still some provisions that still need to be considered. One is in-person requirement, which I said for prescribing controlled substances that will expire at the end of the public health emergency. Also, secondly, the safe harbor that allows high deductible health plans to offer cost-free telehealth services to plan members before the annual deductible is met. This will ensure that plans can support patients that are leveraging virtual care during the pandemic and thereon after. That is set to expire at the end of this year, as in the end of 2022. That is not related to the public health emergency at all. And so where will we see that next year is very TBD. And licensing is probably the biggest topic that we've heard. It's a lightning rod hot topic. And during the pandemic, states declared their own public health emergencies. And in that, they waived a lot of their cross-state professional licensing laws that restricted providers to only care for patients in the states they have a license in. However, now many of those declarations have expired, therefore reverting back to those pre-pandemic licensing policies. So though a federal solution may seem like a great fix, and to avoid like a patchwork of licensures for each provider discipline, so that goes for PAs, NPs, physicians, it's not so simple or at the federal level for three main areas, and I'll quickly go over them. One is licensing and regulation of license is a power given to the states. It's not the federal government. And so it's a little bit of a tussle between federal authority and state authority, and it really has been and historically been at the state level, and that is not going to change anytime soon. In the context of healthcare, you can't really separate state practice laws from licensing laws. So things like scope of practice, women's reproductive regulations, don't allow licensure to be legally separated from practice. And so if the federal government preempts states, which laws would apply? And that's a big asterisk of a question mark, how that exactly would work out. And second, and third, is really public protection and patient safety. So this is probably the biggest concern is if a patient's harmed and needs to be able to seek recourse, what happens to licensure and requirements of the provider that is licensed in which state? And so these are some big questions I've been asked. I really glossed over this just right now, but you can just start thinking about the legal questions that get asked about this. And lastly is remote patient monitoring. I think there's a lot of issues related to it regarding the hardware and software, the regulations around it, and also the use of artificial intelligence. I think there's a lot of interest to enable and to use RPMs to better disease surveillance, early detection, improve diagnosis, support personalized medications and medicines. But how that exactly works is very in flux. And will it become standard of care? Who knows? And the provider community and other communities have to, as stakeholders in this, need to kind of come to some type of consensus. So I'll go to the next slide. I'm just kind of wrap up. I know I went through a number of provisions, but I really do want to give you some quick takeaways. One, there's been tremendous success seeing an extension of telecoverage during the pandemic. And there's just some that are listed here. One, providers and patients have learned to use telehealth. Two, many prefer telehealth for convenience and access. Three, there's been ongoing concern about infectious disease spread. So where will we be with COVID? Will there be another emerging disease? We'll always have telehealth as a backup and be able to supplement in-person care. Technology can be frequently effectively monitor some things that we didn't know that could monitor well before. And so we've had a good test case for that. But unfortunately, do we expect telehealth policy to be including CURES 2.0, which ultimately will be attached to PDUFA? Kind of unlikely. There's still a lot of historical concerns on the Hill when it comes to quality of telehealth, fraud and abuse. But we haven't seen much of that during the pandemic, but those concerns continue to linger in congressional committee leadership. And so, we've been working through that for many years, and we continue to do so in the months to come. And so I'll just wrap up my portion of the presentation with that.
Thank you, Nisha. That was extremely insightful. Just quick question. Do you think when it comes to the licensing issue that Congress will be able to, address that?
Yeah, I'll be really quick. The quick answer is it'll be very difficult. I will say that the federal government has, there's certain offices that have introduced, there's two bills. One's the TREAT Act, which gives reciprocity of licensing for healthcare providers, but that bill is specific to the pandemic. Then just last month, the 3T Act was introduced that basically takes the same language as the TREAT Act, but actually extends it beyond the pandemic. At this point, we don't believe either of those bills are getting traction given the legality and concerns between state and federal policies being in conflict with one another. There's a lot of appetite, but as far as what can be done is a little bit more challenging.
Thank you. So our final speaker today is Ashira Ventries, who serves as a staff attorney at AIMD Alliance. She has extensive experience in researching a wide variety of issues, including public health, health education, human rights, women's rights, and disability. Ashira, welcome to our panel today. Thank you so much for joining us.
Hi, Arika. Thank you. And good afternoon, everyone. I would like to thank HealthyWomen for inviting me to speak on this panel and discuss really where Congress should go next after CURES 2.0. As mentioned, my name is Ashira Ventries, and I'm a staff attorney at AIMD Alliance. Next slide, please. For those of you who are unfamiliar with AIMD Alliance, we are a 501c3 not-for-profit health policy organization that seeks to protect and enhance the rights of healthcare consumers and providers. Next slide, please. At AIMD Alliance, we think really CURES 2.0 is really important because it's really looking at the full cycle of healthcare. And the reason I say it's really looking at the full cycle of healthcare is because it's looking at increasing diversity in clinical trials and how drugs are developed, expanding access through telehealth services like my co-panelists have explained, and really increasing caregiver support in the home and really recognizing that role. And so what CURES 2.0 does is it provides a more holistic look at healthcare. And that's really important because improving healthcare in this country is not a one-issue fix. And so Congress needs to continue to look at healthcare through multiple angles. Next slide, please. Therefore, the next two angles that I would recommend that Congress consider are expanding access to biomarker testing and prescription digital therapies. Next slide, please. So Congress should expand access to and coverage of biomarker testing. So biomarkers are characteristics of the body that can be measured through blood or other bodily fluids that can be objectively measured. And biomarkers can be used to identify genes, proteins, and other substances in cancer treatment that provide better insights into a patient's specific type of cancer. And so in cancer treatments, these can be really helpful for healthcare providers determining which treatment is most appropriate given the patient's specific cancer. So for example, for women with ovarian cancer, they often have a certain gene that makes it more difficult for their cells to repair themselves. And so through biomarker testing, this gene can be identified, and then healthcare providers can employ a specific treatment to target that gene and better help treat women with ovarian cancer. So this information is really powerful in determining the best course of treatment for patients with cancer. But at the moment, it's not widely accessible due to barriers in both private and public coverage. So specifically, when looking at private payer coverage, health plans can often not cover the cost of biomarker testing, or if they do cover the cost of biomarker testing, they subject it to really burdensome prior authorization policies. And so these prior authorization policies can completely impair access to this testing and cause long delays in getting this information. And when we're talking about getting a most appropriate treatment for a progressive disease like cancer, it's really important that patients have this information as soon as possible so they can make an informed decision with their healthcare provider. And when looking at the public side as well, there's also limitations. So for example, Medicare programs are currently limited to covering certain types and stages of cancer for biomarker testing. And there's also inconsistencies in state Medicaid coverage. So at the state level, most states don't explicitly say whether they cover the cost of biomarker testing. And in actuality, less than 40%, according to a 2020 study, actually cover the cost of that testing. But Congress can take action to address this and expand access. Next slide, please. Congress can introduce legislation that would require health plans to cover the cost of biomarker testing. But it's also really important that any legislation introduced on expanding access to biomarker testing includes provisions on how to address prior authorization policies to ensure that these policies don't act as barriers and delays in getting access to this testing. Next slide, please. Second, Congress should expand access to and coverage of prescription digital therapies. So prescription digital therapies, is also called PDTs or prescription digital therapeutics, are FDA cleared evidence-based interventions that use software on digital devices like a tablet or smartphone or virtual reality headset to prevent, manage, or treat a range of conditions and disorders. And what's important about PDTs is that they're different than the health apps that we just find in like our app store. And the reason that they're different is because they're clinically tested like prescription drugs, and they're required to be issued through a prescription by a licensed healthcare provider. Currently, there's a wide variety of PDTs available that can treat multiple conditions such as ADHD, chronic low back pain, chronic insomnia, opioid use disorder, and substance use disorder, but they're not currently as widely accessible as they should be because providers have difficulties billing health plans for these because there's not appropriate coding available. But again, there's a clear opportunity for Congress to take action on this issue. Next slide, please. So Congress can pass the Access to Prescription Digital Therapeutics Act of 2022. So this act was introduced in March of this year by Senators Jeannine and Capito and Representatives Thompson and McKinley. And what this would do would require the Secretary of HHS to create temporary HCPCS codes for PDTs and permanent codes within 2 years of the bill being passed. So this would ensure that healthcare providers would have a means of billing health plans when they use these therapies. Additionally, the bill would also create a new Medicaid payment category for PDTs. So this would ensure that Medicaid beneficiaries would also be able to access PDTs. And really just to sum it up, both expanding access to biomarker testing and prescription digital therapies is in line with what we've seen this Congress already do in recognizing the role that technology plays in healthcare, such as expanding telehealth access. So I think really taking these two issues up is really the next logical step for Congress. Thank you.
Thank you so much. So we have about 5 minutes left, and I would love just to at least get one quick question around to all of the panelists. Essentially, given everything that we've talked about today in terms of the CURES 2.0 package and our ask and wants of Congress, what takeaway do you want the audience to have? Especially as they go back to their respective offices and they're advocating for the for various provisions. Nisha, why don't we start with you?
So, hi, can you hear me?
Yes.
Great. So whether telehealth policy gets included in CURES 2.0, of course, we would, from the telehealth medicine community, absolutely, that's what we would advocate for. And really look at the success of telehealth during the pandemic as a petri dish and as like a proof of concept, and ensure that those get continued on. I know there's still a lot of skepticism and many are waiting for the report that comes out after the omnibus. But keep in mind the anecdotes that we've heard today as to the clinical importance of telehealth and how great it has been, and how good it would be to continue moving forward.
Thank you. Ashira?
Yeah, I would say that everyone should consider that the role of technology in our health and our healthcare system is really evolving rapidly, and we need to make sure that we have the infrastructure, including coverage, to evolve with these therapeutics as they are available. And I think that's a really important consideration as we're talking about telehealth and expanding coverage, that we also think about the broader impact of technology in our healthcare and how we can take steps now to ensure that in the future we don't experience similar barriers.
Great point. Dr. Cothran.
Thank you. I actually think that with the CURES 2.0 infrastructure, I think it's a promising step for us to actually continue to support, recognize, and empower caregivers across condition and lifespan. So just continuing to really strengthen that infrastructure will really be beneficial.
And Dr. Brant?
Yes, I think I'll give a shout out to patient-reported outcomes and just funding to support platforms, workflows, so that we can capture the patient experience. And then finally, for nurses, to encourage to involve nurses who are great problem solvers. And we oftentimes sit on many healthcare teams in organizations to really try to help find answers to difficult questions. So thank you so much.
Absolutely. And thank you for the reminder, Dr. Brant, that this is Nurses Week and we should be celebrating the great work of the nurses across our country. So we are just at the top of the hour. I want to thank everyone who joined us today for this very robust discussion around CURES 2.0. Please, continue to have good discussions as we seek to move this this package through Congress. And thank you to Healthy Women for having this great discussion today. It was such a great session. And please don't hesitate to reach out if you have any questions. A recording of the session will be emailed to you later today or tomorrow, I believe. So you will have access to that as well. And again, thank you so much to all of our speakers who joined us today. It certainly was great to hear all of the various perspectives and insights. And I hope everyone has a wonderful afternoon. Thank you so much for attending.